This procedure was done for an elderly gentleman who had unresectable carcinoma head of pancreas, and the normal method of ERCP, that is through the papillary method, was not possible for this gentleman because of altered anatomy. So we did US guided Choledocho duodunostomy for him to establish a biliary drainage. So the first part of video will demonstrate how we obtained a tissue diagnosis. You can see the dilated CBD, you can see the hypoechoic tumor. Just below the CBD is the curved cystic duct. We make sure that there are no any intervening blood vessels. Put a Doppler. So with the help of 22 gauge needle, we took a fine needle biopsies from this lesion. Finally, histopathological diagnosis was obtained. This patient had carcinoma head of pancreas, and we went ahead with biliary drainage. We will demonstrate how we identify common bile duct and establish the communication into the first part of duodenum. So this is a dilated common bile duct, you can see. So we are puncturing the common bile duct with a 19 gauge needle. The site of puncture is confirmed through aspiration of greenish bile into the syringe. So once we puncture the bile duct, we pass guide wire. Make sure that the guide wire reaches hilum. This is visualized through the fluoroscopy. So once we confirm that our guide wire is passing towards the hilum, we puncture this through a 6 French cystotome. Once we puncture the wall, the aperture gets little bigger with the use of cautery. Once the wall is punctured through the cautery, you can see here, then we deploy the metal stent across the guide wire. We deploy the biliary part of the stent and slowly withdraw, and then we deploy the duodenal part, partially covered stent, and you can see the free flow of greenish bile in the video. So this is how we establish a communication between the common bile duct and the duodenum when the lower part of common bile duct is obstructed. Thank you.